Hi guys, let's get started. I know that we're a bit sparse right now, but with the rain and everything, I think people will come marching in probably within the next 10 to 15 minutes. So a couple of things about today. First of all, today is World Kidney Day. I want everybody to think kindly about their kidneys, and all you guys in the hospital, treat your patients' kidneys, with a great deal of respect. Second, I want to announce, and for those of you, many of you probably saw it in the UofL today, that 5 South at UofL Hospital has received a Beacon Award for Excellence, and it's only like one of 4 hospitals in the state for which that designation has been given. So that's utterly fantastic. I think we can be, with all the bad press that the UofL hospitals had over the last couple of years, this is a great thing. Today is also an exciting day because we have one of our Department of Medicine named lectures. This is the Beverly Todd Towery lecture, which is hosted by the Endocrinology Division. Beverly Todd Towery is a seminal figure for the Department of Medicine. He was born in 1915 and did his undergraduate work at the Western Kentucky State College, which is one of the precursors for what we know today as WKU. He then went to Vanderbilt for medical school, interned there, went up to Boston, did a residency in pathology, ended up going into the service for 3 years, World War II, and then came back, actually then did residency in medicine, at which time he was interacting with Fuller Albright, whom we all recognize, again, Institute, went back to Vanderbilt, actually became a Markle Scholar, started the Division of Endocrinology at Vanderbilt. The University of Louisville was fortunate enough to coax him up here as professor and chair of medicine in 1956. That was a position that he held until 1970, at which point he elected to step down from being chair, but remained as chief of the section of endocrinology. Now, Dr. Towery's name was made as a superb bedside teacher. He was known at Vanderbilt for this and really developed is that legacy of his. It is regrettable that in 1974, he actually contracted viral encephalitis, obviously at a very young age, and never recovered, and this event ended his career. But I am pleased that his friends and family were able to endow this lectureship and carry on his tradition. So with that, I'd like Dr. Steve Winters, the chief of the section of endocrinology, to come up and introduce our guest speaker.
Thank you, Eleanor, and good morning, everyone. Dr. Towery was a thyroidologist, but this year we've involved an andrologist. And has stayed at Penn for his entire career. Peter is a previous associate editor of the Journal of Clinical Endocrinology and Metabolism and a member of the editorial board of Endocrine Reviews. Presently, he is on the advisory board for Nature Clinical Practice in Endocrinology, and he's co-editor-in-chief of the Endocrinology and the Pituitary and male and female reproduction section of Up to Date. He's a member of the Clinical Trials Advisory panel for the NIA. And Dr. Snyder's research over the years has focused on male hormones and growth hormone and looking at bone disease, muscle disease, and a variety of other outcomes related to those hormones. And in the early 2000s or so, Peter was among those andrologists who recognized that there was a very large study of women called the Women's Health Initiative, which changed the way we practice hormone treatment in women, and he felt that men were being underrepresented. So he and his colleagues got together, petitioned the NIA and the NIH. In fact, I was on one of the panels that reviewed their petition. And finally, in 2009, they received funding for a multi-center study, which they called the TTRIAL, which was really the first randomized trial of testosterone versus placebo in an effort to identify the beneficial effects of testosterone treatment in older men. And of course, this has been very widely received because this is a very pressing and very well established issue for primary care and other physicians across the country. And Peter discussed this trial quite extensively at the European Society of Endocrinology and Louisville. And we're happy to have Peter here to tell us about lessons from the testosterone trials. Thanks so much for coming.
Well, thank you very much, Steve, for the introduction. Thank you also for the invitation to come today, for your hospitality during the last couple of days. And thank you for the opportunity to honor the memory of Dr. Towery. As Steve mentioned, what I shall discuss today are the lessons that we've learned from the testosterone trials. And briefly, the testosterone trials are 7 trials that were highly coordinated to answer a single question. And that question is, does giving testosterone to old men who have a low testosterone have any benefit? Here are my disclosures. Most notably, although the testosterone trials were heavily supported by the NIH, they were also heavily supported by the pharmaceutical company AbbVie. So here's the background for the testosterone trials. As men age from, say, 30 to 80 and beyond, their serum testosterone concentrations, either total or an index of free testosterone, their testosterone concentrations decrease. This study was from the Baltimore Longitudinal Study on Aging, but many other studies have shown the same results. This fall in testosterone is not nearly as abrupt as the fall in estradiol in women at menopause, nor is it so severe, but nonetheless, there is a fall. And that fall raises the question, is it a physiologic phenomenon, perhaps adaptive, or is it pathologic, resulting in disease? You've probably heard some names applied to that fall, like male menopause, or andropause, or late onset hypogonadism, and others. And if you think about it, you realize that if someone applies a name to it, it implies that it's a disease. think that that fall might be pathologic is the parallels between the consequences of male hypogonadism. In other words, low testosterone due to decreased libido, decreased muscle mass and body hair, increased fat, decreased hemoglobin and hematocrit. But prior studies of testosterone treatment of old men with slightly low testosterone produced equivocal results. Some showed a little benefit, others didn't. The results were conflicting. In 2003, may seem like a long time ago to some of you, but to me it seems like yesterday. The Institute of Medicine convened a committee to evaluate the evidence at that time that testosterone had any benefit in old men with low testosterone. And that committee concluded that they weren't convinced at all that testosterone treatment of old men with low testosterone had any benefit whatsoever. So that committee recommended to the NIH that it conduct clinical trials of testosterone in older men with low testosterone. And they recommended specifically that the initial trials could be designed to assess efficacy, and that larger, longer trials to assess safety be deferred to wait for the results of the efficacy trials, and that the larger trials not be conducted unless efficacy could first be demonstrated. So the testosterone trials were designed to implement this recommendation of the Institute of Medicine to determine if raising the serum testosterone levels of men over 65 with low testosterone would have any benefit whatsoever. As I mentioned, there were 7 trials. There was a sexual function trial, a physical function trial, a vitality trial, cognitive function, bone, anemia, and cardiovascular trial. They were conducted at 12 sites, all in the United States, from East Coast to West Coast, from north to south. There was a central data coordinating center, a central laboratory, and central reading centers for various specialized outcomes. There were very specific entry criteria. There were some entry criteria that were common, and that for a man to qualify for the testosterone trials had, for any of the 7, had to meet these common entry criteria. The man had to be over 65, had to have a serum testosterone concentration less than 275 early in the morning on 2 separate occasions, and had to have a low risk of prostate cancer. There were many other entry criteria, but these were the main ones. And then each of the 7 trials had its own specific entry criteria, inclusion and exclusion. For example, for the 3 what are called main trials, sexual function, physical function, and vitality, the man had to have subjective and objective evidence of deficiencies in each of those areas. So for the sexual function trial, for a man to be included as a primary entrant in that trial, had to report that his sexual desire was worse than it used to be. But in addition, by a instrument called the DEROGATIS inventory, he had to have low libido. For the physical function trial, the man had to say that his walking was worse than it used to be, but in addition, his gait speed had to be less than 1.2 meters per second. And for vitality, he had to report decreased energy and also had to have a low score on the FACIT fatigue scale. The treatment was either androgel or a placebo gel, double-blindly for 1 year. The initial dose of androgel was 5 grams a day, and the dose was adjusted periodically to attempt to keep the serum testosterone concentration mid-normal for young men. So the goal was physiologic. It was not pharmacologic. Now, if the dose of the gel was adjusted in a man who was using testosterone gel in order to keep his serum testosterone normal, if we didn't do anything else, then that would have broken the blind. That would have told everybody, both the participant and the study staff, that that man was taking testosterone. So what we did to avoid breaking the blind is that when a man was told to change his dose in order to get his testosterone normal, a man taking placebo gel was also told to make a similar change in his dose of gel. So there was still a 50-50 chance that a person was taking the real thing. So here are the results of our screening. We recruited mostly by mass mailings, hundreds and hundreds of thousands of mass mailings at a cost of many millions of dollars. And those mailings resulted in interested men calling one of the trial sites, and when they called, they were screened by telephone. The man, for example, said he had had prostate cancer. He was excluded by telephone. So we had screened over 50,000 men by telephone. And by screening that many men, we then found 23,000 who qualified for and came for the first in-person screening visit. And that screening resulted in 2,200 men who qualified for and showed up for the second in-person screening visit. And that resulted in 790 men who qualified for and enrolled. So if you think about that, we had to screen over 50,000 men to get a little less than 800 who enrolled. I don't know if any of you have children who are high school students or grandchildren who are seniors in high school. During the next couple of weeks, the most selective colleges in the United States will send out their acceptance letters. I looked up recently, last year, the acceptance rate for Harvard College was 4.5%. The acceptance rate for the T-trials was 1.5%. So it's 3 times as hard to get into the T-trials as into Harvard College. A different demographic. So why did it take screening so many people to find sufficient number to enroll? And this number, by the way, was what we were looking for. We successfully completed the enrollment. But it took a lot of work to do it. So the major reason that men did not qualify was that their testosterone concentrations were too high. Only roughly 20% qualified based on the first serum testosterone concentration of less than 275. And then, even those people who qualified by the first serum testosterone, only 2/3 of them qualified by the second. So overall, we lost 85% of those people who were screened at the first visit by the serum testosterone. So there were other reasons for exclusion, but serum testosterone being not low enough was the major reason. So here's what the 790 men who enrolled looked like at baseline before treatment. So they were equally divided between the 2 treatment arms, testosterone and placebo. The average age was 72. They were mostly white. They bordered between overweight and obese, BMI of 31. They had a number of other medical conditions. We intentionally did not exclude people with other medical conditions unless we thought the condition would interfere with one of our endpoints, because we wanted the results to be widely applicable. And so what happened? Those were the men, the treatment, here's what happened. The serum testosterone concentration before treatment, you can see this is the shaded area is the range of normal from 300 to more than 800. You can see that the men before treatment were lower than normal. Men treated with placebo had, as expected, no change during the course of the year. And the men treated with testosterone, the serum testosterone increased to mid-normal and stayed mid-normal for the entire year. So we were successful in raising the serum testosterone and keeping it at mid-normal, just as we had planned. So what about the results of the 7 trials themselves? The outcome. The principal endpoint, the primary endpoint for the sexual function trial was the psychosexual daily questionnaire that measured all forms of sexual activity, and it was conducted by interactive voice response, that's by telephone, every day for 7 days in a row at each of these time points, baseline in months 3, 6, 9, and 12. The men treated with placebo had no change in sexual activity during the 12 months, and the men treated with testosterone had a very significant increase in sexual activity, which was maintained for the 12 months. And there was a very significant difference between the 2 groups. Now you see that I've listed here the term men in trial, meaning the men who specifically qualified for the sexual function trial. But we also administered the questionnaire for each of the 3 main trials. We tested everybody in the T trials for the primary endpoint of that trial. So in other words, these results are just for the men who qualified for the sexual function trial. But we also administered this psychosexual daily questionnaire to all men in the T trials. And here are the results. They're the same. They're actually not exactly the same, but I could have showed you the same slide, and at least I wouldn't have known the difference unless I had gotten these results from our statisticians and they told me they were correctly labeled. In other words, testosterone treatment of men who were old and had low testosterone increased their sexual activity, whether or not the men perceived that their sexual activity was low. Now, we administered a couple of other questionnaires in the sexual function trial. We administered the DEROGATIS interview, which is specifically for libido. And you can see there's a really prominent effect of testosterone on libido in these men. And we also administered an index of erectile function, and there was a significant increase in erectile function. Not quite as striking as libido and sexual activity, but also an increase. So now let's move to the physical function trial. The primary endpoint of the physical function trial was the distance walked. Whoops. Sorry. That's too hard. Was the distance walked in 6 minutes. So I don't know if you're familiar with the 6-minute walk test, but it is highly standardized. We had each of the 12 sites had to have exactly the same course. The course had to be the same distance at every site. The instructions that the staff people gave to the participants had to be carefully scripted. The staff had to be trained at administering this test. It was timed with a stopwatch. And we had a physiatrist who specializes in this test go to each site to observe the staff administering the test once a year to make sure they were administering the test correctly. And at 2 sites, the report was that the staff person was not administering that test correctly, and that person was forbidden to administer that test again, and someone else had to be trained. So we were very careful about the administration of this test. And the primary endpoint was not just the distance walked in 6 minutes, but was the percentage of men whose distance walked increased more than 50 meters during this 6-minute walk test. And you'll see that towards 12 months, it looks like the men treated with testosterone were walking a little bit further than men treated with placebo. But our analysis was not at any one time point, but the entire 1 year of the test, all data from the test combined. And so for the men who qualified for the physical function trial, there was no significant difference between the 2 treatment groups. But since the test was administered to all men, and we compared the effect of testosterone in all 790 men, there was a significant difference. The man treated with testosterone did walk further than the man treated with placebo. So our conclusion was that testosterone does have an effect on walking, although it's a very modest effect. Next, vitality trial. In the vitality trial, the primary endpoint was the FACIT fatigue scale. One end of the scale is fatigue, the other is vitality. Well, you don't have to be a professional statistician to see that testosterone had no effect on vitality measured either in the men who qualified or in all men together. There were some secondary endpoints in the vitality trial. One was the PANIS, the positive and negative affect scale. Testosterone significantly increased positive affect, and testosterone significantly decreased negative aspect. See, both effects were not huge, but they were both significant and both, I'd say, agree with each other. And we also administered what's called the PHQ-9, which Patient Health Questionnaire 9, which assesses depressive symptoms. This is not major depression, but depressive symptoms. And testosterone significantly decreased depressive symptoms. Cognitive function. The fourth trial. The goal of the cognitive function trial was to determine if testosterone treatment would improve cognitive function in men with age-associated memory impairment. There were a number of secondary endpoints, but testosterone had no effect at all on any of the endpoints. Testosterone had no effect on verbal memory by delayed paragraph recall. That was the primary outcome. It had no effect on visual memory. It had no effect on spatial ability. It had no effect on executive function. I won't show you the data because they're bored. It had no effect on any cognitive function. Fifth, the bone trial. The goal of the bone trial was to determine if testosterone treatment would increase volumetric bone mineral density of trabecular bone, and specifically trabecular bone of the spine. The reason this is the primary endpoint is because we had prior evidence that testosterone affects primarily trabecular bone rather than cortical bone. And we used this technique of, we used volumetric bone mineral density as measured by quantitative CT scanning, because that technique can distinguish trabecular from cortical bone, which DEXA cannot, and it avoids the artifacts of osteophytes and aortic calcification, which DEXA cannot, and it allows bone strength to be estimated as well as bone density. We had a central reading center, which just like we had a reading center for cognitive function, and we had the standardization of the physical function trial that I described. So we had a central reading center that trained the technicians at the sites in how to do the CT scanning, which was done on an ordinary CT scanner. But there are quite a number of steps that were needed for quality control to make sure that we're getting the same data from all of the sites. Here are the results of volumetric results on volumetric bone mineral density of the spine, and specifically of the trabecular spine. And you see that testosterone very significantly increased volumetric bone mineral density of the lumbar spine. Placebo, not surprisingly, had no effect. This was an almost 8% increase in 1 year of treatment. Peripheral bone is largely cortical. There was a significant effect there, but it was less than that of trabecular bone. And there was a significant effect on whole bone as well. There was also a significant effect of testosterone on bone in the hip, but not as, it was significant, although it was not as great as that in the spine. There's not as much trabecular bone in the hip as in the spine. And just as we saw that effect on volumetric bone mineral density, there was also an even bigger effect, 11% increase in estimated bone strength in the spine. So overall, I think there was a very significant effect of testosterone on bone. And that's comparable effect on the strength in the hip. Testosterone increases erythrocytes. But specifically in the anemia trial, we wanted to find out if testosterone treatment of, again, this is of men who have low testosterone. We wanted to find out if that testosterone treatment would increase hemoglobin by more than 1 gram per deciliter in men with unexplained anemia. We did this trial in collaboration with a group of hematologists, and they were particularly interested in unexplained anemia in the elderly. And they were the ones who said that if the increase is more than 1 gram per deciliter, that's clinically important. We defined anemia as being less than 12.7 grams per deciliter. I use the term we loosely. It was the hematologist who gave us that definition. But if a man had a hemoglobin less than 10 at baseline, that man was excluded because we thought that was sufficiently severe that he should be evaluated at that point and not randomized to placebo. We tested for anemias of known cause, those men who had hemoglobin concentrations in this range. We measured iron, folate, B12, looked for markers of inflammation. And the hematologists were the ones who classified the anemic men as either having anemia of known cause or unexplained anemia. So here are the results. Testosterone treatment of men who had unexplained anemia, significantly it increased hemoglobin more than 1 gram per deciliter in 2/3 of the men with unexplained anemia. Placebo, of course, had no significant effect. So I was not surprised by that effect, but initially I think I was surprised to find that testosterone had just as good an effect in men who had anemia of known cause, men who had iron deficiency anemia, or B12 deficiency, or folate deficiency. Why is that? Well, when I thought about it, I realized that all of the men in the T trials had low testosterone. Testosterone increases erythrocytosis. So if a man got in the T trial, he's hypogonadal, he may have had some other cause of anemia in addition to his low testosterone, but he had low testosterone. And therefore, increasing his testosterone should increase his hemoglobin. So in retrospect, it should not have been surprising. And finally, the cardiovascular trial. The goal of the cardiovascular trial was to determine if testosterone treatment compared to placebo would decrease non-calcified coronary artery plaque volume as measured by CT angiography. And this is a technique, as you probably know better than I, distinguishes non-calcified from calcified coronary artery plaque and allows quantitation of each. And this technique was also standardized. The personnel at the individual trial sites were trained by Matt Butoff at Harvard UCLA, and all of the CT angiography scans were sent to his laboratory for reading. And here are the results. Testosterone didn't decrease non-calcified plaque volume, it increased it. And it increased total plaque volume. And these are the components of non-calcified plaque, and testosterone increased all of them. So just the opposite of our hypothesis. Testosterone did not affect calcified plaque and did not affect coronary artery calcium as determined by CT scanning, but without the dye. So we also evaluated men in the T trials for adverse events, and we concentrated on adverse events that we suspected testosterone might increase, like heart disease. We knew from the outset that the number of enrollees, 790, was not sufficient to give us any definite information about adverse events, but we felt obliged to collect that information. So, not surprisingly, testosterone treatment increased PSA by more than 1.0 nanogram per ml. And when I say increased by more than 1.0 nanogram per ml, I mean this is a confirmed increase. If there was an increase reported on one measurement, that was immediately repeated to see if it could be confirmed. So we had 23 men who had such an increase in the testosterone group compared to only 8 in the placebo group. That increase led to referral of those men to a site urologist picked in advance at each site to evaluate that man for prostate cancer. But in fact, there was only one man who had prostate cancer, and this is just not at all significant. There was no difference between the two treatment arms in the International Prostate Symptom Score. This is a score. This is a questionnaire that evaluates lower urinary tract symptoms. Testosterone did not increase those symptoms. Testosterone did cause 7 men treated with testosterone to have erythrocytosis. No men treated with placebo. I think that's expected. In fact, that is a lower number of men with erythrocytosis than seen in clinical practice. I think that's because we were so careful to adjust the testosterone dose to avoid overtreating for any extended period. Of course, we're interested in major adverse cardiovascular events, MACE, and those include myocardial infarction, stroke, and cardiovascular death, but there was a total of 7 in each group. So, after spending $50 million and breeding 50,000 men and finding 790 men and treating them with testosterone and placebo for a year, what do we conclude? I think we can conclude that testosterone treatment of men over 65 who have a confirmed low testosterone, that treatment improves all aspects of sexual function, improves walking, but modestly, improves mood and depressive symptoms, but modestly, definitely increases bone density and strength, corrects anemia, but that treatment does not affect vitality, does not affect cognition, and it worsens non-calcified coronary artery plaque volume. There were no, as you saw, there were no differences between the two treatment arms in cardiovascular or prostate adverse events, but the number, 790 men, is just too small a number and followed for too short a period of time, only 1 year, to draw any firm conclusions about adverse events. But as you recall at the outset, the goal of the TTRIALS was to determine the effect of testosterone on possible benefit, not adverse events. So of course, you'll want to ask, well, what are the implications of the TTRIALS for clinical practice? So I think that one implication is that these results show for the first time clear benefits of increasing the serum testosterone in men over 65 who have unequivocally low testosterone, and that's really important to emphasize. But the TTRIALS were not large enough, in other words, didn't study enough men, or long enough to determine the risks of testosterone treatment. So that the results of the TTRIALS will eventually influence the decision to treat or not treat older men with low testosterone, but not until we also know the risks of that treatment, and that will require a trial that's larger and longer. We've actually done some calculations, and the numbers show that it would require about 5,000 to 6,000 men followed for about 5 or 6 years each. So those are the results. I'm pleased to share them with you, and I thank you very much for the opportunity to be here and to honor the memory of Dr. Towery.
I have a couple of medical calls. Are there any reports of any besides the changes in the present? Second is anybody trying to develop testosterone analog that does not that will affect the bone?
So there were no consistent changes in behavior that were reported, to answer the first question. So the second question, are drug companies attempting to develop selective androgen receptor modulators, SARMs, that will have selective effects of testosterone, beneficial effects, but not some of the possible adverse effects, like on the prostate? And the answer is that virtually every major pharmaceutical manufacturer and many startups have been trying for the past 20 years to do that, and no one's been successful so far. There have been several drugs that have made it to early phase trials, but nothing on the market, but not for lack of trying. Well, weight training wouldn't increase testosterone. So there is one way of increasing endogenous testosterone. Well, there's more than one way. One could give human chorionic gonadotropin that would stimulate the Leydig cells of the testes to secrete testosterone. That's actually an approved treatment for men who have low testosterone due to pituitary or hypothalamic disease and want to become fertile. But it increases serum testosterone. It's also possible to increase serum testosterone concentration with the drug clomiphene, which stimulates the pituitary to make LH, and that stimulates testosterone production. And it's been tried. There are a few studies of that, but they're small studies, and I don't think we can draw any conclusions from them. So let me answer that question first. So the question is, did the men who were treated with testosterone have fewer fractures than the men treated with placebo? And in fact, so we made that assessment, not just in the men in the bone trial, but in all 790 men. And we made that assessment not just during the year of treatment, but in the year after treatment as well. And there was no difference between the two treatment arms, but the number of men was too small to draw any conclusions about fractures. It would actually take, and we've done these calculations, it would take the same number of men treated for the same length of time to determine if testosterone reduces fracture risk as it would to determine if it increases cardiovascular risk. It would take about 5,000 to 6,000 men followed for 5 to 6 years each. And the cost, you would ask the cost of that? We have a cost. It's $500 million. No, we did not do that. We measured PSA 6 months after completion of treatment, but we did not measure testosterone then. And the PSA did come down again. Yes.
Always a controversial issue, but versus period-wise. What's your take on the testosterone?
Okay, so two parts to that question. So the first part is, what did we do about sleep apnea in this study? So at screening, the men were asked if they had the diagnosis of sleep apnea. If they said yes, we asked them if they were being treated. If they were being treated for the sleep apnea, they were allowed to enroll if they otherwise qualified. If they were not being treated, they were not allowed to enroll. So we don't think that, so we didn't think that the sleep apnea would have any effect, but we thought it was safe to exclude people who with untreated sleep apnea. So then the second part of your question is, what is my take on the relationship between hypogonadism, treatment of hypogonadism, and sleep apnea? And my answer is that in two parts. One is there are a few isolated reports that testosterone treatment of hypogonadal man would make sleep apnea worse. And that's, of course, the basis why we're interested in this. Because of that, in an earlier study, in 108 men randomized to placebo and testosterone, we purchased sleep apnea machines that could be taken home. We had our study staff trained in those machines, and we tested every subject before and during treatment with either testosterone or placebo, and we tested them every 6 months for 3 years. And I learned how to read the printouts from sleep apnea instruments. There was no effect whatsoever of testosterone on sleep apnea compared to placebo. So I don't think it's real. Yes. Well, I have to say, I don't have the foggiest idea. So my real answer is I don't have the foggiest idea. But obviously, the question is a very practical question because you are describing what often happens in the United States. You are describing that men who really don't have low testosterone, so you said 200 to 400. So we included only men who had lower than 275 early in the morning twice. So these men really have low testosterone. But if a man had a value of 300 in the afternoon, that man has a normal testosterone. So what you described essentially is a group of men who are at least mostly normal with regard to testosterone. So you're describing a situation in which men who have normal testosterone are given additional testosterone. So in that situation, there's a greater chance of side effect, adverse effect, than if a man has a low testosterone is increased only to normal. Now, an additional factor which makes it difficult to makes it difficult to predict what would happen in the situation described is the amount of testosterone, the dose of testosterone that's administered in your hypothetical situation. If the dose is, say, an ordinary replacement dose, that increasing that man's testosterone above normal initially would suppress endogenous LH production, and that in turn would suppress endogenous testosterone production, and the net result might be that testosterone would remain normal. And in that case, there might be no adverse effect. But if the dose of testosterone is more than sufficient to suppress endogenous LH production and raises serum testosterone concentration above normal, then if it's sufficiently high above normal, say as doses of androgens taken by bodybuilders, those have very clear adverse effects. Say they cause erythrocytosis, very profound erythrocytosis. So the answer to your question depends partly on the dose. My personal recommendation would be to be more conservative than that. You may know that the FDA has required drug companies to put on their label that testosterone preparations are approved only for men who have, in the FDA's terms, classical hypogonadism. And what they mean by classical hypogonadism is hypogonadism, low testosterone, that is caused by a recognizable disease, such as a testicular disease, mumps orchitis, for example, or pituitary disease, a pituitary adenoma. And the FDA has required further that the labels state that testosterone is not approved for treatment of men, even with documented low testosterone, due to late onset hypogonadism, exactly the condition that the TTRIALS were designed to study. And therefore, now I think that perhaps the FDA went overboard a little bit, but the FDA was responding to the inappropriate prescriptions of testosterone in men who never had testosterone measured even. So my personal recommendation, and this of course is in the absence of definitive data about risk. We now have definitive data about benefit but not about risk yet. So until we have the risk data, my personal approach is not to treat old men, even with documented hypogonadism, unless that hypogonadism is much more severe than I would require for treatment of classical hypogonadism. So I would require serum testosterone concentration to be below 200 early in the morning on at least 2 occasions before I'd think about treatment. But that's my personal approach, and based on no risk data. Benefit data, but no risk data.
Lovely lecture. All of our visitors. Thank you again.
Thank you. Thank you very much. That's lovely. That's great. But can I get this through security?
No, we'll ship it to you.
The last answer alluded to the question I was begging to answer is, did you do severity subset analysis in any of this? You're treating under 200. My clinical experience was that if I attempted the treatment